Next speaker is Dr. Kiran Balagopal. He will be talking to us on management of IOP elevation after ocular surgeries other than glaucoma surgery.
Okay, so I'll be mainly speaking about the medical management part. IOP elevation can occur either in the early stage or late after surgery. Common surgery scenarios are cataract, via surgery, and corneal surgery. Here, the threat to vision is very unpredictable. Moderate small spikes are very common, but what you have to be careful is extremely high IOP spikes and even moderate spikes in eyes with pre existing glaucoma or damage to the optic nerve. In evaluation, you have to know the details of the surgery. This is easy if you are the primary surgeon, but if not, you have to sit with the primary surgeon and have a good discussion. Then you have to find the mechanism of IOP elevation. Is it a closure? Is it an open angle? Is it pre-trabecular, trabecular, or post-trabecular? And then treat accordingly. You have all the normal tools that a glaucoma specialist has, but the way you use them and their effectiveness may be varied. Sometimes you may not be able to do a proper tonometry, your tonometer may not work, or the patient may not be in a condition to give you accurate IOP values. Gonioscopy may be difficult. You have slit lamp 90D, and if you're lucky, you have the UBM, B scan, etc. But sometimes you have to rely on your clinical judgment and digital tonometry. And in your armamentarium, you have the normal all the usual drugs are there, but you have to be extra careful with the PG analogs, pilocarpine, and topical carbonic anhydrase inhibitors. Let us come to cataract surgery first. There are some risk factors which Mini Madam has already touched upon, and let us directly come to a case where the patient complained of defective vision and mild pain in one eye 1 month after SICS cataract surgery in a high volume situation done at a hospital in Calicut. She was the mother of a doctor. In the right eye, the vision was 6/60. Reportedly, it was much clearer immediately after the surgery. IOP in the right eye was 46. Left eye also was high, 26. The right eye was white, and there was corneal edema. The right pupil was sluggish due to the high IOP probably, and PCAL was there, and left eye pupil was okay, NS3 plus PSC. And because of the corneal edema, fundus view in the right eye was poor, and because of the cataract, fundus view in the left eye was poor. So we only had the IOP and the corneal edema. So initially we thought it is a steroid response and stopped the steroids and started beta blockers. After 1 week, vision was 6/60, applanation still was 6/60, applanation 32, and off steroids, and we dilated and saw the fundus and found that the cupping was 0.8. So this was a case of missed POAG which underwent a cataract surgery and developed a steroid response on top of the POAG. So after the patient was started on beta blockers and latanoprost was added, the IOP came back to normal and the patient became fine. Another patient, a unilateral cataract post-trauma. There was a 3 o'clock hour zonular dialysis with vitreous in the AC. After a vitreous clearance, I did a CCC and placed a CTR and did a routine phacoemulsification. First day, patient was okay, 6/9 vision, but there were 4+ cells in the anterior chamber. By the end of the first week, patient had pain and corneal edema. Vision had dropped to 6/60. IOP was 42. AC cells were 4+, mainly pigmented cells. With Diamox and Combigan and steroid hike, the IOP came down to the low teens in 3 days. And with maximal dilatation, I could find that some part of the IOL was probably outside the capsular bag. So I again took up the case to the OT and used some hooks to retract the iris and found that the edge of the haptic had come out through the CCC because the CCC was not well centered on the crystalline lens. It was centered on the pupil, so one edge of the CCC was closer to the equator, and through that the edge of the haptic had come out and it was rubbing on the posterior surface of the iris, causing a pigment dispersion. So this was a case of secondary pigment dispersion glaucoma, and it needed a repositioning of the lens. I redialed it, and then the patient was fine. Then we come to another more recent case. The patient presented after 7 weeks of uneventful phaco surgery and he was off steroids after 1 week off steroids with pain, redness and blurring. Vision was 612, applanation 20 in that eye. There was some circumcorneal congestion, clear cornea relatively, pigments on endothelium, AC showed 3 plus cells, pupil was mid dilated, IOL and fundus were okay, and I didn't see the case. Another of my juniors had seen the case, so they diagnosed a case of post-operative uveitis, having stopped the steroids and restarted on moxifloxacin plus dexamethasone 2 hourly and added nepafenect. So after 2 days the vision suddenly decreased to 6/36 and the IOP went up to 55. So on re-examination, the right eye had corneal edema, pigment clumps on the endothelium, AC was deep, pupil was still mid-dilated, not reacting, fundus view was hazy. After 2 tablets stat Diamox, fundus view was clear and fundus appeared normal. This was the picture after the IOP came down, and did a gonio and found that the gonio showed open angles with heavy pigment 360 degrees. Areas of pigment loss were seen on the iris close to the pupil edge. Pupil was not dilating. So hiked up the steroids and gave Diamox TID, Combigan and Dorzox. 1 week later, still the IOP was high despite Diamox 3 times daily. Vision had improved, cells were still 3 plus and pupil was same. And IOP remained between 20 and 30 with intermittent spikes, and after 1 month the IOP became normal. And then the patient developed some influenza and he was lost to follow up for 3 weeks, and after that he came back with a normal IOP only on topicals. He had stopped all the Diamox. Then I found that the pigments were also not there. Then I again checked his IOP by applanation, and the next day he called me and said that he has again developed irritation. Then I called him the very next day and saw that he had again developed pigmented cells in the anterior chamber and there was some circumcorneal congestion. This happened 2 or 3 times. Every time the patient comes with a quiet eye, I examine with IOP checking also, and next day patient develops pigment dispersion and also pain and uveitis like features. So on retrospective thinking and also some Google search, I found it out to be, I think it is a case of a unilateral case of body, that is something known as a bilateral acute depigmentation of the iris or a bilateral acute iris transillumination. Here there is not much transillumination, but this is seen when the dosage of moxifloxacin given after the cataract surgery is it's an ocular toxicity of the moxifloxacin, probably because the dosage of the moxifloxacin intracamerally was a little on the higher side. And about the IOP spikes and inflammation spikes, I think it is due to the moxifloxacin drops applied at each visit after the applanation. So I'd like expert's opinion also regarding this case at the end. Next we have pars plana vitrectomy. Even if it is uncomplicated, 10 to 20% people develop glaucoma. The first month is very critical and they have to follow proper head positioning as advised by the retina specialist. It can be an either open angle or angle closure glaucoma, and the commonest is pupillary block, then comes steroid response. So 3 things, either buccal or silicone oil or gas. And when you place a buccal, if it's a high buccal, encerclage or anterior to the equator, it can impair the venous drainage from the vortex veins, causing ciliochoroidal effusion. This causes a congestion and anterior rotation of the ciliary body, pushing the iris lens diaphragm forward, and it causes an secondary angle closure glaucoma. So in cases of very hazy corneas, you can use glycerin to clear the cornea, and also if you have access to anterior segment OCT, you can use that to find the status of the angle. So then you have to use intensive steroids and maximum dilatation cycloplegia and laser PI if required, and loosen very tight buckles. And let us come to silicone oil. Silicone oil is a very buoyant thing, and when the patient sits upright, it can compress the superior angle and develop glaucoma. 50% of patients with silicone oil do develop IOP elevations, and in the early stage, mostly due to pupillary block. Late stage, mostly due to emulsification and migration into AC, more with the low viscosity oils of 1000 centistokes or still than with the high viscosity newer ones. Also neovascular glaucoma is also quite common in the late stage. With regards to gas, it is more with C3F8 because it expands more and stays longer, and it can be either an open or angle closure mechanism. With regard to gas, only one thing, that is the IOP measured even with the relatively low displacement tonometers like applanation or Donopen, they can be falsely low. So you have as low as you can be underestimating the IOP by as much as 15%. So whatever gas you use, it's better to use an isovolumetric mixture like 20% SF6 or 14% C3F8. Head position is important, and when it enlarges, when it expands to maximum size, that is the time when you get maximum risk of glaucoma. You can treat it with carbonic anhydrase inhibitors, beta blockers, or alpha agonists, and you have to remember that all types of mechanisms can be at work here. Good thing about gas is that it gets absorbed after some time, and so risk of glaucoma also goes away. This is another case, that is PDR with vitreous hemorrhage, underwent a very big surgery at a different hospital, and at the end it was closed with air, and patient developed headache and vomiting. And when she came to us, she was on Diamox, Combigan, Dorsox, Homide, antibiotic and steroid, and vision was PL, and IOP was 48. The patient was on Diamox ER, so that was made to QID and also given mannitol IV. Then the IOP did decrease. So the question here is, does mannitol work after vitrectomy? Theoretically, mannitol shrinks the vitreous, so if vitrectomy is complete, it should not work. But vitrectomy, usually some part of the vitreous is left behind, so that does shrink. That is one mechanism. And also mannitol acts on the hypothalamus via osmoreceptors. It causes a decrease in aqueous secretion. That is also another way through which it works. Next case, it was a pre-existing glaucoma. TRAB IOL were done already on latanoprost and very deep cup, and he developed an RD, underwent RD surgery with silicone oil insertion, and initially there was some IOP rise that subsided, and after that at 4 months underwent silicone oil removal. Next day there was hand movements vision, epithelial edema, trace hypopyon, TAS was diagnosed and treated with systemic and topical steroids, which were weaned off pretty quickly. After 1 month postoperative, patient still was on latanoprost when he developed CME. So latanoprost was stopped and switched to Diamox and topical medicines like Combigan. Was restarted. So patient did not redevelop CME after that, but field loss was there mainly due to the RD. So this is just to highlight that prostaglandin analogs, especially with vitreous surgeries and aphakic eyes, can predispose to CME. Next case is a case of silicone oil for RD, suddenly presented with pain, headache and vomiting, vision HM, IOP 52. So corneal edema was initially cleared with Diamox and mannitol, and gonio done. There was iris Bombay and multiple YAG PI were performed, and on topicals IOP decreased, but at second week the IOP shot up again and PIs all closed, and PIs were reopened again and came 4 or 5 times for repeat PI, and then was lost to follow up. But she went to the original place of surgery and then had a silicone oil removal, and again came back. At that time 80 was only 8, vision had dropped to PR inaccurate. This was the final picture, 360 degree PAS, 360 degree PS, and all fibrotic tissue over the IOL. After keratoplasty, nearly 33% patients develop glaucoma, and this is the second most common cause of graft failure. But here the important thing is the corneal thickness may be variable. So applanation may not give you a correct picture always. So tonopen may be a good idea. There are many risk factors like already mentioned, but here one unique risk factor is the suturing. Superficial sutures, tight sutures, or same sized donor, large graft, etc. These can cause compression and collapse of the trabecular meshwork, and that can lead to glaucoma. And I'll just come to issues of surgery. Any surgery for glaucoma after PK carries a 30% risk of graft failure. At any rate, we have to avoid a shallow AC, and in the first surgery PK itself, 1 or more patent PIs are a must, And whenever TRAB is done, it has to be combined with MMC or any antimetabolite. A tube in the AC is very risky. It will cause graft failure. Better to place in the pars plana if possible. Sometimes you may even have to resort to cyclophotocoagulation for refractory cases. And let me come to a case. Final case. Underwent a KP for fungal corneal ulcer with hypopion, therapeutic KP. First day graft was clear with epithelial edema. Immediately you have to suspect that IOP is high if DM folds are not there the first day. So IOP was high, given Diamox and Combigan controlled, and it remained stable near 16. At 6 months everything was clear when the patient developed a brimonidine allergy. So switched to dorzolamide plus timolol combination. Then again IOP was normal but presented after 3 weeks with blurred vision, 6/60. There was diffuse graft edema, shallow DM folds, and AT was 12. So suspected a graft rejection and hiked the prednisolone to 1 hourly. No change in 2 days. So then suspected sodium potassium ATPase pump blocked by the topical carbonic anhydrase inhibitor. So stopped dorzolamide and switched to netarsudil when the patient became fine. So I think I'll wind up my presentation, already running short of time. Thank you so much.